And now for our big ones, our cardiovascular. So the various effects on the heart are categorized by the chronotropic effect is the one that affects the heart rate. The inotropic effect, which is the force of contraction, and the dromotropic effect is when the drug alters the velocity of the conduction of electricity through the heart. So all three types effects on the heart can be positive or negative. So for example, if there is a positive chronotropic effect, the heart rate has increased. If there's a negative inotropic effect, the heart is not squeezing as forcefully. So cardiac glycosides are a class of medications that are derived from plants. Those drugs are they block certain ionic pumps in the heart cell membranes, which indirectly increases calcium concentrations. However, the cardiac glycosides generally have small therapeutic index and are associated with numerous side effects. Then we have our antidisrhythmic medications. They have long been used in the pre-hospital setting to treat and prevent our cardiac rhythm disorders. These medications can have direct and indirect effects on cardiac tissue. Our antidisrhythmics are further classified into the following 4 groups according to their fundamental mode of action on the heart. Sodium channel blockers. They slow the conduction through the heart. In other words, they have a negative dromotropic effect. The beta blockers. They reduce the adrenergic stimulation of the beta receptors. The potassium channel blockers. They increase the heart's contractility. They have positive inotropy and work against the re-entry of blocked impulses. And the calcium channel blockers. They block the inflow of calcium into the cardiac cells, thereby decreasing the force of contraction and automaticity. They also may decrease the conduction velocity, negative dromotropic effect. So these are just a few. Antihypertensive medications. So when we're looking at antihypertensives, you have to work with the doctor to figure out, okay, what exactly is going wrong? Why is my pressure high? Over 75 million people in the United States have hypertension. So we have diuretic medications. Causes the kidneys to remove excess amounts of salt and water. So we want to decrease our sodium. By lowering the total volume, they reduce the level of stress placed on the cardiovascular system. In particular, diuretics lower the preload on the heart and decrease the stroke volume. The vasodilator medications act on the smooth muscle of the arterioles and veins. This property explains why nitroglycerin, your vasodilator, is so beneficial in treating myocardial ischemia. Unfortunately, the dilation of these vessels prompt a response from the sympathetic nervous system. Consequently, when vasodilators are used to lower blood pressure, the patient must also take medications that inhibit the sympathetic nervous system. My sympathetic blocking agents, including beta blockers and adrenergic inhibitors. So my beta blockers mentioned earlier compete with epinephrine to bind with available receptor sites, thereby diminishing the effects of the beta stimulation. Angiotensin converting enzyme, ACE inhibitors, target the renin-angiotensin-aldosterone system, which partially controls the blood pressure. The ACE inhibitors suppress the conversion of angiotensin 1 to angiotensin 2, thereby decreasing the blood pressure. Angiotensin 2 is a potent vasoconstrictor that promotes smooth muscle contraction in the arterioles throughout the body. This constriction raises the blood pressure by increasing peripheral resistance. Calcium channel blockers that were mentioned earlier have antidisrhythmic and antihypertensive properties. By causing the dilation of the coronary arteries, calcium channel blockers enable more oxygen to reach the heart via coronary artery dilation. In addition, they prevent the contraction of smooth vascular muscle, which reduces resistance in the peripheral vascular system. Then we get into our anticoagulants, our fibrinolytics, and our blood components. So our antiplatelets, so we think about our patients that have blood clots. So they end up with a DVT, deep vein thrombosis. So with those, they can cause that life-threatening crisis, such as our acute coronary syndrome or our stroke. So when we're seeing that, the antiplatelet agent in our MI interfere with the aggregation or collection of those platelets. So we're trying to break them up. And this is why when you see on the 12 lead that it looks like they're having an MI, you give them an aspirin and it's like, that EKG looks different. Well, this is why. It's trying to break up those platelets that are forming together, especially if it's just a little bit. Now, if it's a pretty big solid group, you're not going to be able to break it up. Your aspirin has substantial antiplatelet properties and has proved important in pre-hospital setting because of its ability to minimize the damage to the myocardium in acute coronary syndrome. Your anticoagulant drugs, as their name suggests, works against coagulation, thereby preventing your thrombi from forming. So some patients can be prescribed anticoagulants on a long-term basis. These are our patients that we get called out for that have a fall, otherwise fine, but because they're on a blood thinner, they're on that anticoagulant, we go ahead and take them in because they have a tendency to bleed. We have already thinned their blood out because they're on these anticoagulants. So, we want to make sure that they don't have a bigger bleed going on in their head or somewhere else that is going to cause a bigger issue. And then after your clot has formed, a fibrinolytic agent may be administered to dissolve the thrombus and prevent it from breaking off and entering the bloodstream. Your fibrinolytic agent promotes the digestion of fibrin, the protein involved in forming a blood clot. The use of a fibrinolytic medication in the pre-hospital setting remains controversial, and in some circumstances, other forms of reperfusion therapy may be indicated. I don't know anybody in North Carolina that goes ahead and starts a fibrinolytic agent for their stroke patients. If we can be at a stroke center within an hour, most of the time, the benefit outweighs the risk. The problem with your fibrinolytic agent is they can bleed, and if I don't know that 12 to 15% that have a hemorrhagic stroke and they're not quite to the point they're presenting, truly, I've got the gaze and the pupils, and I know it is a bleed, I'm going to cause this patient to bleed out. So giving it without a CT scan, I will not. I don't give fibrinolytics without that CT to know 100% this is not a head bleed. And there's still a chance of them bleeding. That's always a chance that we take, putting them in the back of our truck to go to a PCI center, and now they start bleeding out. It's like, okay, I don't like this. I've been lucky so far. I've still had a lot of patients that don't have good outcomes, but at least they don't die in the back of the truck. So we keep their TPA going and try to reverse it.